正理 position.
Are you seeing my screen? May I ask if you can see my screen? Hello?
Not yet.
Let me try again. It is not giving me the option to share the screen. I think you might need to make me a presenter in Zoom. Oh, bear with me. Actually, I think I've got it. Try this. Can you now see my screen? Can you see it now?
Yes, we can see it now.
Is it on full screen? Is it in presenter mode?
Yes.
Yes, we can
Oh, great.
see your screen. I see your screen now, ma'am.
Okay, great. Okay. Thank you. So I thought today I would give you a rundown of the sort of work that I've been doing in my academic life, and also how this academic research has fed into the work that I do now as in the industrial sector. So for most of my career, I was an academic researcher, as mentioned in my introduction. I was a professor at Oxford University, a professor of modelling and epidemiology. And throughout my career as an academic, I always was very interested in how my research could influence policy making in health, but also particularly enjoyed working on solving mathematical problems as well. And so I'm going to give you a presentation about that on a few pieces that are also relevant in the industrial sector where I currently work in the pharmaceutical company GlaxoSmithKline. So I'm going to give you a few case studies where myself and my students and my colleagues have integrated mathematical, statistical and economic methods in order to address real life or real world health problems. I'm going to talk a little bit about malaria and also about COVID-19. So let me start with an example from the field of malaria. Here I want to talk about supporting the investment case for eliminating malaria from the Asia Pacific region. Now, this project came from the organization APLMA, the Asia Pacific Leaders Malaria Alliance, and what they were looking for was a fully evidence-based, quantifiable investment case for eliminating malaria from the Asia Pacific region. And so in order to do that, we needed to build, first of all, a mathematical model, a transmission dynamic model, which was spatially explicit, so multi-patch, multi-country, with the countries interacting with each other, and also multi-species, because in the Asia Pacific, there are two main malaria species and they're different in the way that they transmit. So we needed a multi-species, multi-country malaria model. And the other element that was absolutely essential to include in this model was economics and costs. And all of those ingredients were brought together in collaboration with a global health finance expert who used this information to put together an investment case for the elimination of malaria from the Asia Pacific. And what you can see here is essentially the output, the result of all of this work. You see this incredible number here of all the different scenarios that we simulated with this model. The reason being that we wanted to express the results of the model in lots of different ways. So we also produced a user interface which allows any user, and particularly not a modeling specialist, it allows them to navigate through all of the modeling scenarios that we ran. And it also gives you some nice summary results. For example, this map here shows what would be the minimum package required of interventions, because you have to use multiple interventions to combat malaria. What would be the minimum package in each country to reach elimination by a particular year? And I think we chose 2030 for that year. And throughout this presentation, you'll see QR codes, and those essentially will take you to papers and publications and so on, in case you would like to see more detail about this work. What I want to show you here is how the mathematics interacted with policy over many, many years to build up a strong evidence base, a strong mathematical modelling evidence base to support malaria elimination in the Asia Pacific, where actually anti-malarial drug resistance was also a major issue in that region. And so, as you can see, we start from even very strongly mathematical approaches, equilibrium analysis. So there were pieces written in the early 2000s, mid 2000s, on the nature of the system, the malaria transmission system, and how mathematically you could explore different options for eliminating and eradicating malaria, and exploit what we understand about the mathematics underpinning the transmission. We also showed that a simple set of differential equations could reproduce almost all the behaviors that were shown in the more complex mathematical models for malaria transmission, including individual-based models and all sorts of very complicated models. We showed that a well-written set of differential equations could essentially give you most of the same information. And then there were a whole bunch of other pieces that came together that ultimately led to a mathematical modeling system that was sufficiently robust to support investment cases and decision making for malaria elimination in a large global region like the Asia Pacific, and actually beyond as well into Africa also, and South America. And as you can see, there were many applications, all starting from that equilibrium analysis all the way through to these policy-facing pieces. So next, I'd like to talk about something that we did recently, and I noticed that in the room you have my colleague, Professor Emmanuel Afolabi, and so this is something that Emmanuel collaborated with us on. This is the COVID-19 Modelling Consortium. So during the COVID pandemic, a group of us came together from many countries around the world to work together to use mathematical modeling to support decision making for different countries around the world for how to address the COVID-19 problem, which is very different in different countries. There are different age structures of the population in different countries. There are different sets of interventions that are realistic for that country, for that culture, for that economic setting. And so as a group, we produced a shared model which allowed mathematicians and other people who came and wanted to use modeling to adapt this model or compare it with their own model to explore COVID-19 in their own countries. And one of the things that one of the principles we had for this is that it should be people, modelers in their own countries, doing their own models to support their own decision making. And you can read more about the COMO Consortium or ask Emmanuel about more information about that particular event and endeavour. What I can show you here is that similar to the malaria approach, we hid the maths behind an accessible user interface. Why did we do that? Because this is policy-facing modelling, and it was a very complex system that would be impossible to explain and discuss in detail during an emergency. So we decided that the best way would be to have a user-friendly interface and allow and of course publish the model in full and in detail as well for scientific robustness. But for the use for policy making, this user interface was extremely useful for not just the decision makers, but also for the modelers, some of whom had only just started doing modelling and were suddenly in a position where they were advising their Minister of Health or even their president. And here's an example of one of those, the work of one of those new modelers, Ainura Moldok-Matova, now Dr. Ainura Moldok-Matova, who was a PhD student when she began using the COMO model and working with her Minister of Health in her home country of Kyrgyzstan. So what about a different approach, also policy facing? Now, in this case, this is a piece that we did to explore the potential impact of a treatment for COVID-19 called dexamethasone. And this treatment was for people who were already hospitalized, and it was to reduce their risk of dying of COVID once they were already in hospital with COVID-19. And it was requested, in this case, it was UK modelers working for their country because it was requested and used by the UK Prime Minister's office. We produced a different kind of model. This was not a transmission dynamic model. We used a static model, a static economic model, in order to estimate, make a sort of, how would you say, conservative estimate of how many lives could be saved with this drug, both in the UK and also globally. So the results are here. And what I want to show you particularly about this modeling approach was that although this tree diagram can look quite complicated, it is simply a product of multiple probabilities. And so at the end of each branch is just the product of each of these, at the end of each, branch here is a product of each of these minor branches. So the benefit of that is that you can actually write the entire model on one page. And so this gives complete transparency and reproducibility, which was a priority for our partners. So here's another approach. So now we've talked about transmission dynamic modeling. We've talked about simple static economic models. And now I'm going to talk about a sort of combination of a dynamic approach, a sort of semi-mechanistic statistical approach, or what I call here a mechanistically influenced statistical approach. So what was the question here? The question here was when the COVID pandemic in the UK started, there were no reliable tests available because COVID was a new disease. So we suspected, sort of the orange line, this is the data, we suspected that the data was being underreported in the first wave of the COVID pandemic in the UK. And so how did we interrogate this hypothesis? How did we test this hypothesis using mathematics? Well, what we did have later on was, well, actually quite early on, was serology data. So we had, there were two pieces of data that were quite robust and informative, and one of them was serology data, so testing people's blood, a random group of people testing their blood at these different points during the pandemic, a random sample of people, and having a look to see how many people had antibodies for COVID-19. And then we also, now if those antibodies did not wane, if they did not leave a person's body, then the antibody, the serological prevalence, the seroprevalence, would actually be the equivalent of all of the people that had been exposed, because if you've been exposed, you've got antibodies, and so you just have a look at what percentage of people have got antibodies and you know who's been exposed. However, in the case of COVID-19, people would be infected, they would produce an antibody response, and then those antibodies would decay over time and ultimately leave their body. So someone testing negative for antibodies could mean that they had never been exposed, or it could mean that they had been exposed but quite a long time ago and they'd already lost their antibodies. So if you combine antibody data with mortality data, which is also very well recorded in the UK, then you would have something that could tell you, those two things together could tell you how much exposure there had actually been. And that's what we did. And I'll show you the equations in a moment. And what we predicted here was the amount of exposure that had happened. And opposite to the orange line, which starts off with a low peak and then has a higher peak later in the second wave, our model predicted that the first peak was very much underreported and was probably much, much higher in the first wave than it was in the second wave. And what you can see here are is the mathematics that goes that underpins this result. And what we used was essentially we needed to understand the timeline of individuals who become exposed, and then they get symptoms, and then after they have symptoms, they can go through all of these stages. Some after they have symptoms, only some of them get symptoms, and of those who get symptoms, only some of them get severely ill, and of those who get severely ill, again, only a few of them unfortunately die of COVID, and that happens 3 weeks after exposure. Coincidentally, if someone has been exposed and they did not get severely ill and die, then that's around the same time as they would start testing positive for antibodies when they recover from their infection. So we exploited this result in order to produce this this equation here for those who are exposed. Now, at the same time, we have this quantity alpha, which is called the infection fatality ratio, which indicates of what is the proportion of all people who are exposed who would die. So you can include this, and then you have you're able to include the mortality data in your formula. And so you now have your mortality data, and you have your seroreversion rate, and by fitting this formula to the seroprevalence over time, we are able to estimate both the rate of seroreversion and the infection fatality ratio. And we were able to do that long before other methods were available to do the same thing. And I'm happy to say we got it right. How much more time do I have? Hello? Would you like to hear about COVID-19 during pregnancy?
10 minutes, 10 minutes, 10 minutes.
10 minutes.
10 minutes?
Yeah.
Okay.
10 minutes. 10.
Yes.
Okay, great. In that case, I'll very briefly show you what we did for this one. So this is building on the model, the mechanistic statistical approach we used before, and adding a set of differential equations. And the idea here was to estimate how effective it was for shielding during pregnancy. Now, I don't know if it was the same case in Nigeria and other countries in the African continent, but in New York and in the UK, women who were pregnant during the COVID pandemic were advised to reduce their contact with other people during their pregnancy. And we didn't know how effective that could be. There was no randomized controlled trial to tell us how effective that was. But what we do have is a situation where some women would have been giving birth after the epidemic wave in well, all women who were giving birth after the epidemic wave, some of those would have started shielding before the wave because they're pregnant for 8 to 9 months. And then those sort of 8 or 9 months after the wave had occurred would have started shielding after the wave. And so what you can see here is if you can work out the difference between these two populations, you've got the effectiveness of that intervention. So that's what we were trying to estimate. And we used a set of differential equations to do it. So we started here. So these are people who were negative for both the virus and their antibodies. Then they get infected and then they become positive for the virus, but they still haven't raised antibodies. So they're negative for the antibodies. Then they seroconvert, and there's a period of time where they're positive for both virus and antibodies. And then they get rid of the virus and recover. And now they're still positive with their antibodies. And then eventually they revert and they lose their antibodies as well. So the beta here is the same beta that I was using previously, the rate of seroreversion. And so using this approach, we were able to combine this model with our previous model and estimate what the effectiveness of shielding was. And we got, I think it was about 40 or 50% of infections were blocked with this method. So to conclude, in the field of real world evidence and health policy, mathematical methods are particularly useful when you're combining different disciplines together, and they can really add value to the evidence that we already have from field studies and other more traditional methods of data collection, because you can combine data sets together and you can pull out information that you wouldn't normally directly measure. They're not a substitute for the standard approaches, but they do give more information. They do add value. They might give a direction to go in for more research. And so ideally, these methods are used hand in hand with field and laboratory research to essentially give a bit of foresight and to help explore which avenues are worth pursuing in terms of real world evidence. In order to do this kind of work, you need a combination of skills. You need both the mathematical knowledge and the understanding of different technical disciplines, but also an understanding of the of what are the big pictures in terms of real world epidemiology, health policy, and so on. What are the big questions that need answering? What are the data gaps? What's important to explore? What data are there? And in order to do all of that, you need a multidisciplinary group, and collaboration and communication are essential. So that's it from me. I hope that gives you some insights into the kind of work that I've been doing and what can happen in the world of health and health policy and pharmaceuticals using applied mathematics. Thank you.
And now, thank you, income. This presentation report to how Nigeria goes in public health. And people different diseases using COVID-19 and then malaria, all other diseases that she has been able to consider in this presentation. That was a very beautiful presentation. I really appreciate your that presentation. Okay, so before I go on to entertain questions, our director, Professor Emmanuel Afolabi, I would like to say hello to you.
Hi, Mr. Thank you very much.
Hello.
So I knew this out some years back, and then we should one of the most outstanding British lady professor I've ever met in my life. And now she has a very large heart, and we have worked together. In fact, the last time we were working on malaria projects and the modeling, we sent to her our justice to the work. And I want to announce to you, the paper just got online this morning, infectious of this morning, and the paper of malaria that you looked at, that you were commenting on the last time on the show of this symptomatic class. So it has been published online this morning. Oh,
Fantastic.
I mean, she's been a very mentor, and the first time I ever talked to her, it's not 10 years now. And I came for a workshop in Ireland, and then after that, I went to our lab as a TWAS visiting fellow in 2017. You remember?
Yes, I do.
So, you know, she was one that actually gave me an idea about Swiss tropical and public health institute. Now she came back from Swiss and told me that there are some network in Swiss. I would like to be able to work with them. I said, fine, I'm good. The next thing I saw was that he brought up the relationship. I wrote a proposal, then we worked together. And to date, the collaboration still continue. I've enjoyed a good relationship that I cannot close my mouth not to talk about it. Now, why am I saying this now? All of us need men. Men are gross. You can't do science alone. Science is not just about sitting down in your class or your office and formulating all the problems and all of that. You need connection. You need network. And someone said networking works. You need good network. You know, I was working with a student then. Do you remember Elisha? Remember
Yes.
Elisha?
Yes.
Yeah. So Lisa was the first person that bought a laptop for my student. She bought a laptop. Yes. This are really academic compounds. You know, when Roke was to start our masters, we didn't have money. I just came back from Swiss. There was no money and all of that. And there was a little project we were doing on. I think it was from Big Data. We got a project for us from Big Data. Remember? And then 9,000 pounds. And you know, the first tranche was 1.5. And I called her, I said, I have a student, she's stranded, she just came back from NYSC, there's no money and all of that. What do we do? I need scholarship for a master's student. And she said, oh, don't you think that one of these your tranche can settle a bill? I said, that'll be good though. So she eventually just asked to send 1.5, and I gave the money to the lady to complete our master's. She's here. She's here now. So, yes, the first paper, the second paper is, yeah, so we have really invested in a lot of Nigerian people, and we really appreciate you. Can you give her a round of applause? So, We are still interested in working with you, and I hope very soon I'll be sending some people to UK to come and work with you in the last. Thank you very much.
All right, that's a very good
Wow.
one. I have
Thank you.
used some paper. Prof is just breaking the news. My phone has been off. I'm sure Prof was not put it on the platform. So now that I'm hearing it, I think I'll coordinate much more strongly. We are not going home today because some paper has been published. All right, so congratulations to us. I'm very happy to hear that news. All right, thank you. Now, questions. Professor Mr. White had done beautifully well, so let's ask questions. I have a question actually. So questions? Okay, so I'll give number. I have just one hand up. Please check online participants in case they have questions. All right, so I give the mic first to the physical participants here. So then, if I don't have any other question, I'll have my own. Thank you.
Yeah, thank you. I actually enjoyed the presentation and I looked at the.
Can you move the microphone closer to your face? Because
Okay,
I can't hear you. Yeah,
can you
that's
hear me?
better. Yes, thank you.
I actually followed your journey, industry and the classroom. Like for me in my field, I'm into agricultural economics. And one of the problems we have in this part of the world is that of using cross-sectional data. I don't know if you have some little hints on that, because we work with a lot of cross-sectional data, and mostly good researches require panel data and time series data, but those things are not actually available here. The ones that you see, they are usually being sponsored from foreign lands and all of that. So is there a way out of that? Thank you.
Thank you, sir.
Well, that's a very challenging question. Thank you. I mean, I've used cross-sectional data before because I think sometimes you have to use whatever you've got, and sometimes in those cases, perhaps you can't answer all the questions you want to answer. So one thing is to be realistic about what you can get from the data and what you cannot get. So that's step one, is to I think modelers quite often get into a situation and where you feel under pressure to give more answers than the data will support. So one thing is to be honest about what the data can tell you. But secondly, I think with cross-sectional data, sometimes you have a series of cross-sectional data that can be very useful. Also, I've used cross-sectional data where there is essentially there's the history of what happened in that data that can tell you a story even in the cross-section. And I'll give you two examples. The first one is if you look at demographic data. And if you look at the demographic data that you see today, different age distributions, that is a product of the different, the ways that the birth and death rates have changed over the years. And so you can see that pattern even when you only look at the age profiles of people now. And you'll see things like birth rates dropping or mortality rates dropping. You can see evidence of that in the data that you see now cross-sectionally. The other data that you can look at cross-sectionally is age serological data. So anything that involves age or some other sort of signature of time passing can help you to build up a historical pattern without seeing all of the longitudinal data through time. So without knowing more about the particular type of cross-sectional data that you have, I can't give you any more advice, but I suggest that you look for signals like that. And also think about if it can't answer the question that you want it to answer, are there any other pieces of information it can give you? So sort of squeeze out everything you can from those data. I hope that helps.
Okay, thank you so much. And then I think we have three more hands. Okay, so I'll now hand over to Professor Oyèdèjì.
Hello.
Thank you, Professor Lisa, once again for the insightful presentation. The first talk that you gave on inferring exposure from serology to mortality, you quite mentioned one of the limitations of serology, which includes if the antibody wanes over time, then we'll miss out some that probably have been exposed. But one other limitation will also be capturing active infection, because as you're aware, the antibodies takes about 2 weeks, thereabout, for it to be produced. So it's most likely we miss out, those within that framework who have active infection. But of course, you captured that when you were presenting the talk on pregnancy. So how were you able to cope or take care of those with active infection within that framework for the other first presentation? Thank you. Hello.
Thanks. Thank you for that question. Well, the way that I was able to account for it is I was not looking to capture active infection. So the piece, the initial piece where I was looking at just antibodies and mortality is if you put those two together, you have two unknown pieces of information. One is the infection fatality ratio. So you've got the shape of death cases over time, but you don't know what that means in terms of how many infections there were 3 weeks prior that would have led to those deaths. So that's the one thing you don't know. The other thing that you don't know is the rate of waning of antibodies, of people converting from positive to negative. And so because you have two unknowns, you also have two data sets, the mortality data set and the prevalence data set. That allows you to then estimate both of those values together. Once you have those values, the result that you have is you have an estimate over time of people who have been exposed. So not people who are currently infected, but like a cumulative, it would be a cumulative graph that would always be increasing of all the people that we think, based on those data, that had already been exposed. In order to then get the new incidence rate, the incidence of new infections from that cumulative curve, you take the gradient. So if you take the gradient of that curve and then move it back 3 weeks, you've got the incidence of all new infections. So that's how we did it.
Thank you so much for the explanation. Now, Mr. Pham, you raised it. All right, thank you so much, Professor Lisa. So my question is coming from the conclusion, the second point that says that combining multiple data sets and methods can give additional insights. Right. So I want to ask the first question, that to what extent can one have or combine multiple data sets, considering the fact that sometimes when you are doing data-driven work, maybe you are coming up with a mechanistic model that is data-driven, maybe that has to do with combining
trending data, you have the malaria incident, the prevalence data. And one of the things you're going to be doing at the end of the day is that you want to fit the model to the data, and you also want to see some things from there. You want to see how it's able to capture the prevalence data and all of that, see how noisy that these things can be. So how do one handle such challenges when it comes to fitting it in order to get a reasonable result? So that's number one. And then the second one is, does it mean that the more the data, the better the model, considering some of these challenges that are inherent with maybe mechanistic models? Thank you.
Okay. Thank you so much. So if you, I'll deal with your second question first. The more the data, the better the model. If you're a statistician, the answer is absolutely yes. Because those models are driven by data entirely. When you have a mechanistic model, I think it's always better to have more data, but with a mechanistic model, what you're doing is using knowledge of the way the system works, which has come from other information, you know, everything in the literature, everything you know about that particular system, you're using that in combination with data. So it's a different kind of data. The mechanistic model itself is not built in a vacuum. It's built with all of the knowledge about that system. So I think mechanistic models allow you to cope with less data, especially if you're thinking about the future, what might happen in the future. A statistical model can help you for 2 to 3 weeks, but a mechanistic model could take you a lot further, because a mechanistic model can answer a question like, what if we start vaccinating against this disease? We've never vaccinated before, so we've got no data on how it would work in a large population. We've got maybe clinical trial data. So what do you use then? You use a mechanistic model to make those predictions. In answer to the short answer is yes, the more data there is, the better. But there is also, I think, no substitute for really understanding the system that you're working on, the biology of it, or if you know the mechanism of it if you're not in the field of health or biology, but understanding that mechanism well enough, because especially in a sparse data environment, you could write a model that is completely wrong mechanistically and it will fit your data. So you cannot say that because you've got a good fit, you've got a good model. Yeah. And that's a mistake that a lot of people make. And I've actually taught that in classes. I've had people fit deliberately. I've given them the wrong model to fit and they've got a wonderful fit. And I said, what does that mean then? And then I show them where the model that generated the data is different model. Yeah. So I think understanding, there's a very interesting field called identifiability analysis, which is very important as mathematicians in this field to explore, which allows you to understand the relationship between models and data and how they can inform one another. Your first question was, how do you cope with those challenges? Well, I think I've answered that question partly by understanding whether a model is identifiable or not with the data that you're given. So you may be able to uniquely estimate all of the parameters in your model by fitting it to the data that you have, and you may not be. And what you need to do is be aware of when your model is identifiable and when it isn't. You can still use an unidentifiable model, and I did write a paper with some colleagues on that topic. So you can use it to explore future scenarios, because especially if you use methods like Bayesian inference to fit your model to the data, But what it can't do is measure precisely any of the parameters. You know, I could talk about that. You found my favorite topic. I could talk about that for a long time, but you know, please do explore, if you haven't already, the area of identifiability and model identification and the link between those two things.
Okay, thank you so much. That a very beautiful one. I enjoyed this answer. I want to also ask a question, draw your attention to something. In the course of the presentation, I saw that you use serological data to estimate exposure, and together with the mortality rate.
Yeah.
And then at the end, you were able to also estimate case reporting ratio, where you were able to see that the data, the case reporting ratio, you were able to get the case reporting ratio from that. I want to believe that after fitting the model to the serological data, you were able to estimate your parameters, which you now use to simulate the cases, and then maybe compare with the reported cases to see what the discrepancies are.
That's right.
But now,
Yeah.
okay, good. Yeah, but the case of that's because we are dealing with serological data. But if we have, say, reported cases in malaria, for instance, where we don't have serological data for that, we have reported cases. So how do we get to know what the reporting ratio is? You know, you have talked using multiple data. I was thinking that I want to know if my thought is right, that if we combine DHS data with monthly reported data, maybe unfitting simultaneously, we may be able to get case reporting ratio. But if you are not bringing such data in, will it still be right? Say we have only monthly reported cases alone, will it still be right to estimate case reporting ratio using just monthly reported cases data that we have from our model?
Very challenging. You would need another piece of information one more piece of information in order to begin to estimate your reporting ratio for malaria. So you can't do it with reported cases alone. Excuse me. What you would need to do is one way to do it is with the age distribution of cases, because when malaria peaks at different ages, it indicates different levels of prevalence in the population. So that's one extra piece of information that you could use. A different one that's just as useful that you could use is you could use cross-sectional data, actually. So prevalence data. So you've got your incidence data, which are the cases that usually it's people who've come for a treatment, right? So not everybody gets the treatment, so you don't see every clinical malaria case. However, a lot of malaria control programs also round about once a year or once every few years, they also do a prevalence survey where they take a random sample of people and they see how many people actually have an active infection, who actually have parasites. And so your model should be able to predict both incidence of clinical malaria and prevalence. So if you put those two together, that should help you to find the reporting rate.
Thank you so much. So, would like to say anything after?
Thank you very much. So these are some of my observations, like having been working with the National Malaria Elimination Program. Now we have had to be confronted with a lot of data, maybe at the state level, subnational, and where we have to look at the various incidents monthly incidents and all of that. But there are some parameters in our models, especially like the transmission rates or transmission probability. You find out that when you look at the data you have, the data has to do with the number of cases per month, and then the question that comes in is that you want to estimate beta. Beta is transmission. Transmission is not equal to cases directly. So you find out that transmission is a function of many factors like social and other things that do play. So it's not a straight line thing that you can really assess. But I've seen so many papers that people just they just come up with a particular parameter estimation using routine data to estimate transmission rate or transmission probability. So what do you have to say about this going forward? Thank you.
So are you asking me what I think about different methods for estimating this transmission rate using malaria data?
So
and how useful they are.
Yeah, my question is like my view to that you cannot use the routine data to be able to estimate routine data only to estimate transmission rate, because
Yes,
transmission rate
Totally agree.
is not equal to cases, number of cases. So we need other data. We need information, maybe serological data or some other prevalence data to be able to
Yeah.
even possibly climatic data to be able to get what is really going on in terms of the transmission.
Totally agree. And I think what you need to do is essentially triangulate using several pieces of data. So as I mentioned before, there's age structured data as well, which is very useful. There's prevalence data, as you mentioned. Serological data, seen it used for Vivax malaria, that's starting to be used for that. But I think you can do quite a lot with age structure, with prevalence, and with incidence of cases. Now, the other thing that I think is really essential to also have information on is the coverage and the types of interventions that are being done as well, because that also will influence your incidence rate. So the more treatment, the more time, the harder you look for cases in order to treat them, the more cases you'll find. Yeah, and that doesn't mean that you're giving people malaria because you're trying to treat them for it. It means that you're finding lots of cases that weren't there before. So quite often, and I've seen this signal in other malaria data sets, they start doing more treatment, early detection and treatment, and their incidence rate goes up. And it's because they found all of these cases that otherwise people were suffering from without any treatment. So that's a case of the case detection ratio going up, the reported cases are going up, the true number of cases is coming down because of the treatment. So it's very complex, and I think the minimum set you need to understand it is the age profiles, the case detection rates, prevalence, cross-sectional prevalence surveys, and age, and coverage over time of different interventions. You put all of those together, and then you can start to understand where you are with your malaria transmission.
Okay, thank you so much, Professor Lisa. Well, can we please put our hands together to appreciate Professor who had really delivered greatly. I know that some of the questions some of us are asking are also questions we have encountered in the course of doing our work, and it's a great one that she's bringing light into them.
And I think this is one of the reasons we come together for conferences like this, for people to learn, gain ideas, and then share, knowledge. We really appreciate you for your beautiful presentation. We enjoyed it so much. And we'd like to have you another time. I get to know it's already night where you are, so we allow you to go and rest so that we can continue that whole conference. Thank you so much. Enjoy the rest of your day.
Thank you so much, and thank you for inviting me. And I hope you enjoy the rest of your conference and make lots of collaborative links and have, an exciting time. Wish I was there.
Thank you. Thank you. Thank you. All right. Honestly, it's been a great time together, listening to people from the industry, listening to people in the academics, and then combining these ideas together. I know that this kind of engagement will spur many of us into action to do something more meaningful with what we are doing. Like we already have the tools, like the first presenter said, a lot of mathematics has been packed into our head. All that is important is to translate them into actionable insights, which I believe is the reason we have gathered for this 3 to 4 for this 4 days. And I hope that we engage this time to interact, to network, to meet people, ask questions, and then see how we can better our career. Now it's time to settle the middle belts. I think many of us will be expecting that all along. If you don't know the middle belt, just stay back, and then while you watch other, settle the middle belt. Once you know, the earlier you know, the better for you. But in case the food has finished before you get to know, no problem. Next time you'll get to know earlier, and then you'll be the one to know on time. So now that means